Assalamu alaikum. First, I'd like to congratulate you, Dr. Adil and the scientific committee for a very successful program, and I'd like to thank you for having me part of this program. I was warned that I have only 8 minutes, so I need to be ultra fast, though the subject is, as you can see, a very big subject and matter of debate and discussion. I will talk about minimalistic complete revascularization solution case-based debate, and my talk specifically about PCI. First, let me just discuss with you the notion of complete versus partial revascularization. No uniform definition of complete revascularization. We overuse this, we sometimes misuse it, but we need to be careful. There's no uniform definition for complete revascularization. Is it anatomical or functional assessment? If you review the reports of syntax trial, what matter is functional complete revascularization, not anatomically complete revascularization. And talking about PCI as a solution for multivessel or complex PCI, remember you have patients with heavily calcific aorta. How many times we hear this in our heart meeting and combined meetings? Or patient doesn't have good conduits, or there is no good targets. Patient is very high risk because of multiple comorbidities, weak heart, extreme age. These are very common scenarios. I mean, it's not something rarely seen. We discuss this in our day-to-day practice. In fact, the complex high-risk percutaneous intervention represent 30 to 40% of PCIs, and it's driven by old population, surgical turn down for bypass, and patients with comorbidities. So let's go back to the basics. We need to have shared decision-making algorithm taking in consideration patient-centered care. We need to have informed consent and multidisciplinary team discussion, and consider the patient background in our decisions. Surgical ineligibility. 1 in 5 patients with left main and multivessel disease are declared surgically ineligible. So it's not something uncommon or rare. You see this on regular basis in your practice. Surgically ineligibility, not addressed in the current guidelines, and they are excluded from clinical trials even though they remain symptomatic. Let me just take you through scenarios, since this is case-based discussion. This is 37-year-old male that we have seen in our practice, poorly controlled diabetes, admitted with ACS, normal ejection fraction, and he has cath which shows 3-vessel disease, diffuse coronaries. Nobody probably will argue that this is very diffuse, advanced coronary involving the distal left main, the whole LAD, circ, and ramus as well. His RCA is diffuse disease. So this patient was discussed and offered bypass surgery, mainly arterial grafts. 3 months after his surgery, he was admitted with ACS, and this is what we found. The insertion site of lima was severely stenosed, and the RCA graft was occluded. So what should we do? I mean, we need to have PCI. Do you have other option other than PCI? Patient was taken. I will just cut it short and show you the final result. LAD was fixed, and my colleague surgeons will agree that probably this is good left main LAD result, and this was his RCA after intervention. My point is not to advertise for PCI from the beginning, but this is something that we need to have this for the patient care and patient outcome. And remember, 20 to 40% of patients may experience asymptomatic graft failure as determined by CT scan in 1 year post-bypass. Patient's consent is a very important issue. We have patients that they are probably good candidates for surgery, but for whatever reason, they cannot go for surgery. I have seen patients, they said, if we will go for bypass surgery, we're going to lose our job. So will you leave them till they face their fate? So this patient is 55-year-old male smoker, admitted with ST elevation, inferior MI, and this is his left system. So his presentation is inferior MI, diffusely severe disease, circ. LAD is excluded from the ostium, and this is his RCA. So the on-call team dealt with the culprit lesion, and he underwent primary PCI to the RCA, and then he was brought for team discussion and offered surgery. patients just simply disappeared. He just left the hospital because he was told there was no other option but surgery, and then readmitted after 9 months with another ACS. So he was taken to the cath lab, and this is his left system as it was 9 months back, and his stent was patent. So if you just leave him, maybe you'll just he will come again. Maybe I'm not sure if he will be able to come to the hospital in the third event or no. So he was taken to the cath lab. His circ was fixed, and his LAD were fixed. So I think he has complete revascularization. So I'm just bringing these cases just to bring to your attention that we need to have strong CHIP program, high-risk interventions for these sort of patients. And an intervention for this patient is not cosmetic. It's not only for symptom relief. It's for survival. Let me take you to the last scenario. 57-year-old gentleman admitted with stroke. And while he's in hospital, he has ACS. And these are his coronaries. You see tight distal left main and occluded RCA, as you can see from the retrograde collaterals from the left system. And this is his RCA. Recent stroke, admitted with ACS. I'm not sure if the surgeon, maybe you will take him, but he has ACS, and you don't want to subject him to a procedure with a higher risk of having stroke again. So discussed in a combined meeting and was taken for multivisual PCI, and this is his result post PCI. And this is his RCA. I think he has reasonable complete revascularization. So high-risk complex PCI is needed for this sort of patients. Keep in mind phases of patient-centered care and treatment of coronary artery disease, pre, peri, and post-procedure, and consider factors that may make surgical intervention higher risk than PCI. And finally, selecting a revascularization modality should be determined through shared decision-making and a risk-benefit assessment. And thank you.